Thank you very much. And as I said this morning, it's a pleasure to be here at this excellent conference today and to see this morning such a large audience interested in the diabetic foot, which was very encouraging on the first day of the meeting. What I'd like to do now is to talk a little bit about some of these topics, certain things I cannot focus on in 20-25 minutes on diabetic nephropathy. Now, this was given to me by my good friend Shashank Joshi down at the APICON meeting 2 weeks ago, and it summarizes the problem in India. I first came to India more than 35 years ago, and this is what you see. And now we see, sadly, McDonald's. We stopped on the way in the car from Mumbai airport to here yesterday, and they've got everything there, even Kentucky Fried Chicken. And this is what we would call the affluenza that is affecting India, which is, of course, at the forefront of the diabetes epidemic. And it was a pleasure 2 years ago in Bangalore to share the stage with Sri Narendra Modi. And he got up and said, the biggest threat to the survival and health of India is no longer malaria, no longer tuberculosis, it's diabetes. And he's right. Now, as you know, diabetes affects all parts of the body, and the complications, the microvascular complications, which is my particular interest, of course, are silent if you don't look for them. And the power of screening, as I mentioned this morning to the audience on the diabetic foot, is evidenced by what's happened with retinopathy in the UK. Retinopathy was the #1 cause of blindness in working-age adults after the setting up of a national screening program where everybody with diabetes has a non-retinal photograph once a year, and those with worrying changes are sent immediately for ophthalmology review. Diabetes is now no longer the leading cause of blindness in the UK. So screening is powerful, but we have to do it. So we'll focus now on diabetic nephropathy. And the consequences of diabetes and nephropathy are really worrying. As we know, life expectancy is reduced by about 12 years in diabetes with a previous history of cardiovascular disease and MI. But if you look at the data from Leif Group's brother, Leif Group is, I was talking to him yesterday evening from Sweden and Finland. His brother, Per Henrik Group, leads up the FIN-DIAN program, which is one of the largest prospective studies of diabetes in the diabetic nephropathy in the world. And look at the frightening data here, the relative risk of mortality if you've got microalbuminuria, macroalbuminuria, or end-stage renal disease. It's frightening. It's a deadly disease, and we need to prevent it, and we can prevent it if we screen patients early on. And data from the Pima Indians here, from Nelson in Arizona, again, if you've got proteinuria, look at the huge increased risk again of mortality. And here is a study that diabetic chronic kidney disease is the major predictor of mortality in type 2 diabetes. The white bar, if you've got an eGFR glomerular filtration rate of less than 30. And you see if you've got macroalbuminuria plus that, there's the adjusted mortality rate. And we know that all-cause mortality in patients with type 2 diabetes can be stratified by baseline eGFR. And you see here, really, the terrible load and burden that these patients with diabetic nephropathy carry. And we know that end-stage renal disease in the United States, and the graph continues to rise over the next 10 years. It's flattening out a bit now, but diabetic nephropathy is the commonest cause in my country, in the United States, and here, of patients ending up in end-stage renal failure. I've been running for the last 30 years a very large diabetes renal clinic where we see patients at all stages of diabetic nephropathy working with a nephrologist. And it's that team approach that matters. And in that clinic, we not only have a diabetologist, a nephrologist, we have trainees in diabetes and nephrology, a diabetes specialist nurse, renal nurse, podiatry, the whole lot. And here's the changes in numbers of end-stage renal disease due to diabetes in that same period of time. It's frightening, and the same is happening here. Here's a study, again, cardiovascular risk is greatest when both diabetes and chronic kidney disease are present. Here we are, myocardial infarction plus kidney disease. Look at the increased risk, not only of myocardial infarction, cerebrovascular disease, and peripheral vascular disease. So the added burden of diabetic kidney disease on top of diabetes is like the Greek mythology Sisyphus, who was compelled in hell to roll an immense boulder up the hill only to watch it back down again and to push it back up. This is what the burden of patients with diabetic kidney disease carry. So what is the face of diabetic nephropathy? And how do we diagnose and classify it? Well, microalbuminuria, and this is what everybody with diabetes in the annual review, every patient with diabetes not known to have renal disease should once a year be screened with albuminuria. For microalbuminuria, this is normo, this is albuminuria, 20 to 200 micrograms per minute. We do this now on a spot urine sample in the clinic in the morning. And this is highly predictive not only of developing nephropathy, but also of mortality. This can be reversed in the early stages, especially in type 1 diabetes, by good glycemic control and near normal blood pressure control. It's difficult for patients to realize when they get established diabetic nephropathy that the blood pressure matters more than the blood sugar. The blood pressure matters more. And the patients found that difficult because they've been hammered for years, blood sugar, and now most of my patients in the clinic now are doing home blood pressures. So microalbuminuria, and then of course we have macroalbuminuria, which is dipstick positive with the clinisticks. What about patients with type 2 diabetes? Well, here's an old study from Paolo Fioretto, who I was pleased to work with when I was president of ESD. She was one of the vice presidents from Italy. And this study, when she was working in the States, if you look at microalbuminuria in type 2 diabetes, only around 30% have classical changes on biopsy of diabetic nephropathy. So this is the minority in type 2 diabetes. A lot of it's vascular and various other non-specific changes that you see on renal biopsies. So the progression of diabetic nephropathy, we know, this is the natural history, untreated. Hopefully we don't see that too much more. The impact of glycated hemoglobin and standard deviation of serial HbA1 on progression of nephropathy is well known in the early stages. Glycemic control, and this is known from the 1980s and 90s by studies from Italy and from London and from the USA. Tight glycemic control can reverse microalbuminuria, as can ACE inhibition or ARB blockage. The intensive glucose control and macroalbuminuria, you see there is just here as well from all these studies in type 2 diabetes, including the Accord Advance and, of course, the UK PDS, which was the largest study ever, which we were one of the centers. And these all have an impact. So glycemic control favors reducing the risk of macroalbuminuria. So the natural history of diabetic nephropathy in type 2, clinical type 2 diabetes, there may be functional changes, structural changes, but these may not, as I've already said, be typical of diabetic nephropathy. And then rising blood pressure, which we really must crack down on. We're aiming for age-matched normal blood pressures, microalbuminuria, progressing proteinuria, rising creatinine, and end-stage renal disease. And the risk of cardiovascular death increases as you move to the right on this graph. Now, I'm not going to focus too much on this because there are a number of different formulas for estimating the glomerular filtration rate, such as Cockcroft-Gault formula and the creatinine here. The data can be adjusted for normal body surface area of 1.73 meters. These are old studies. But now we use the eGFR, and I'm not going to go through these because you don't really need to know them, just to let you know that there are a number of methods of measuring glomerular filtration rate. So how do we define chronic kidney disease? Well, these are the classical stages of renal dysfunction or function in diabetes. Of course, stage 1 and 2 relatively normal, stage 3, stage 4, and stage 5. End-stage renal disease we would classify as late stage 4 and 5. Now, these have problems. This is what's said to be established renal disease. These have problems, especially in older patients. And many of our patients with type 2 diabetes are 60s, 70s, 80s, even 90s. So do up to 50% of elderly patients have chronic kidney disease? Of course they don't. This is the problem we have. And that is, if you say the eGFR of 30 to 60 is chronic renal failure, then many normal older people are going to be misclassified as having renal disease. The natural history of glomerular filtration rate is that it declines with age. So here's a paper a couple of years ago, 2 or 3 years ago, in the British Medical Journal, looking at chronic disease in the elderly, disease or disease label. About 50% of patients aged 75 or more meet the criteria for chronic kidney disease. Their eGFR maybe 45, 50, 60. But the risk of end-stage renal disease is minimal in these older patients. So we need to have epidemiological risk stratification, but not particularly in the elderly population, and individualization is the key. Many patients in their 70s will have an eGFR of 45, 50, which is entirely normal for them, and it's very anxiety-provoking to say, well, you've got chronic kidney disease. So you need to take into account the patient's individual situation, especially regarding age and what their actual serum creatinine is. So what is the prevalence of chronic disease? And here's a study. Again, this is the Nephron study from Australia. 52.9% of a selection of a large number of patients with type 2 diabetes, half and half, male, female. 53% had normal kidney function. Now you see the microalbuminuria, macroalbuminuria, and here's the end-stage renal disease here. So this gives you the overall distribution in a random selected population of type 2 diabetes. What are the implications for clinical practice? Well, when you think about it, most glucose-lowering medications are eliminated via the kidneys, and primarily or secondarily eliminated. And decreasing renal function means decreasing clearance rates of these drugs. And several anti-diabetes medications should be adjusted as the patient progresses in renal dysfunction. Some might be contraindicated even in mild to moderate renal disease. Here's a study looking at declining renal function, also increases risk of severe hypoglycemia. And the black column here is the risk for severe hypoglycemia. And you can see the huge increase in patients with chronic kidney disease and probably eGFR less than 45 plus diabetes. Without diabetes, of course, there you see without chronic kidney disease, much lower. So we need to consider, what are we aiming for? Are we aiming to really crack down on the glycated hemoglobin, or try and minimize the risk of hypoglycemia? And I would suggest to you that the evidence is that in early diabetes without macroalbuminuria, either type 1 or type 2, glycemic control is very important in preventing the incidence, the development of diabetic nephropathy. But if you've got established chronic renal failure, the evidence is not as good that glycemic control is important. The evidence is much stronger that blood pressure control is important. And as I said at the beginning, this is absolutely crucial. So if you look at the risk factors for hypoglycemia, the biggest risk factor, as we learned from Brian Freer in recent studies from Scotland, the biggest risk factor for severe hypoglycemia is a history of previous severe hypoglycemia. But all these are important. Long duration of type 1 diabetes associated with loss of hypoglycemic awareness, and as I said, previous hypoglycemia, over ambitious targets. And when I was president of EASD, we revised the EASD ADA guidelines for the management of type 2 diabetes for personalized approach. So if you're 75 or 80, you've got a history of cardiovascular disease, but you haven't got complications of microvascular, then the risk of hypoglycemia is greater for you than the risk of getting the complications. So less tight control is indicated in such a person. And certainly with established renal dysfunction, we shouldn't be aiming for near normal glycemia. Why is this? Well, it's prolonged insulin half-life. And you forget that 20% of gluconeogenesis actually comes from the kidney. So this is lost as well. Impaired glucagon production and so on, altered drug kinetics. Here's an old study from clinical diabetes, but drugs such as glibenclamide or glyburide in the United States, metformin I'll come back to, and the DPP-4 inhibitors, of course, linagliptin is excreted in the bile, and that's safe at all stages of renal disease, and we use that in patients even on dialysis. And even allogliptin, which is another DPP-4 inhibitor, is relatively safe, down to a GFR of 30. As for the newer ones, SGLT2 inhibitors, of course, depend on renal function, and they're not to be used in patients with established chronic renal disease. Despite all this, look at sulfonylurea use in Australia. There seems to be no change in using sulfonylureas as eGFR falls. And these drugs are particularly dangerous because they can cause hypoglycemia, and their elimination may be slowed. And therefore, I would suggest to you that in patients with diabetic nephropathy, we shouldn't be using sulfonylureas. Metformin use, the same from the Nephron study. This is falling, but it's still, a lot of patients are on metformin with an eGFR of less than 30. Now, if you go back and look, where is the evidence that metformin is not safe? It's pretty flimsy evidence. Most of the worry came from a risk of lactic acidosis on fenformin from the old UGDP study. And in fact, metformin is really based upon expert opinion rather than true fact. And I have to admit that I have patients in this group still on metformin on a lower dose as long as we watch them regularly in my renal clinic. So this was a review by George Bakris from Chicago and Mark Mullich in diabetes care, looking at the use of metformin. Lactic acidosis, they would say, and I would agree, is extremely rare even in the elderly. Metformin is perfectly safe down to an eGFR of 30. It's a very good drug, tried and tested. We've had it for 50, 60, 70 years. In those with a lower eGFR, care should be taken, especially with comorbidities, and metformin use, strictly speaking, remains contraindicated in those with an eGFR of 30. Though, as I said, in patients that I'm watching carefully, I carefully stray out of that one and have got patients with eGFR of 25 on metformin and have never had a problem. You know, you've got to be careful. I guess you could be taken to court, and I'll quote this. What about treatment? Well, the best treatment is prevention. Either can you reverse it? Well, possibly you can partially reverse it in patients with early diabetic nephropathy with ACE inhibitors, ARBs, and so on. Blood pressure control matters. Most likely at this stage you can slow it. And it's been a pleasure to have been working in the diabetes renal clinic that I set up back in 1987 with my good friend Professor Ram Gokal, originally from Mumbai. And we ran that clinic for many years. Sadly, he's retired. But I still run it with a nephrologist, and the most rewarding thing is to see patients who came to me in the 1980s with microalbuminuria, high blood pressure, and I've got one patient who's exactly the same age as me, which I will not tell you today, but I've followed him for 30 years, and his eGFR is just the same as it was when I first met him. Blood glucose control, of course, it's important. We know from DCCT, the conventional group, the impact, of course, was good, and there was the metabolic memory effect on diabetic nephropathy from tight control. So it continues to prevent albuminuria even in the epidemiology of diabetes and its complications study years after the tight control ended, which was back in 1993. And they followed up patients, and it's still there, that intensive effect of 6-7 years of tight control. This metabolic memory, even though these patients' control has slipped and those with conventional treatment has improved, and they've joined together. After the UK PDS ended, we see a similar change. The metabolic memory occurs there. The legacy effect, if you wish to call it, that's the English way. Metabolic memory is the American way. But this is still there, especially for microvascular disease. Smoking and diabetic nephropathy, a deadly combination. And we see this from the Finn-Diane study. Here are the smokers, and you can see here cumulative incidence of nephropathy is higher in the smokers than the non-smokers. So the speed of kidney deterioration is related to the number of cigarettes smoked per day. I'm not going to talk about blood pressure lowering because you all know that. This has been around for years. The old studies of Hans-Henrik Parving, who's still on the lecture tour, and the effect of blood pressure control in slowing the rate of decline in established diabetic nephropathy, published 30 years ago. Of course, ACE inhibitors and ARBs are helpful in type 1 diabetes. Old studies here, but they're still trained today, captopril, whichever one you use. And type 2 diabetes, similar. This is trandalapril in the Benedict study. So it's the same for type 1 and type 2. And I could show you many of these studies, but they all show a similar result. The multifactorial treatment, the original Steno study and the follow-up by Peter Gade and colleagues from the Steno showed multifactorial intervention, lipids, blood pressure, aspirin, cardiovascular risk, exercise, etc., has a huge impact, and the Steno 2 study showed a similar result. So, diabetic nephropathy, we try to achieve optimal glucose control to prevent. If you've type 1 diabetes, 20 years, no nephropathy, then we're aiming for very tight control. Stop smoking. Blood pressure should be age-matched normal, and use ACE inhibitors and or AR blockers, and lipid-lowering agents, of course, most patients will be on anyway. When kidney failure the best treatment for kidney failure is prevention. The second best treatment when you get to this stage is transplantation. We've got a huge experience of not only renal, but simultaneous pancreas renal transplant. And of course, we've got peritoneal dialysis, and we were a large center for that. But it has its advantages in diabetes. You haven't got such fluid swings of volume, patients with autonomic neuropathy. Vascular calcification makes difficult access for many patients with diabetes needing hemodialysis and so on. But I have to say that hemodialysis is more the norm today. I know that Gokal was one of the world experts in CAPD, and when him retiring, I guess it's changed. But look at this. Listen to patients. This is a lovely article from the British Medical Journal where patients were writing what it's like to be on dialysis. This patient, Mr. Evans, being on dialysis isn't really a life, it's not even half a life. This woman, very observant, non-diabetic. Dialysis is brilliant, of course, but deeply horrendous. But look at this, clinical observation. Here's a non-diabetic patient watching what happens. On the dialysis unit, patients suddenly appear with amputations. But before that, they've had heavily bandaged feet, followed by crutches and then wheelchairs. That's watching the natural history of diabetic patients on dialysis. This need not happen. We had a number of studies supported by Diabetes UK and the American Diabetes Association with my good friend Larry Lavery from Dallas. And in a large study, we showed that dialysis is an independent risk factor for foot ulceration. If we've got end-stage renal disease on dialysis, you've got a four-fold increased risk of a foot ulcer compared with a patient with the same EGFR who has not yet started dialysis. Mortality is horrendous. And as diabetes is the number one cause, we believe that foot care units or foot care, delivery should be on the dialysis unit. These patients are in there 4 hours, ideal chance for education. This is the most frightening data that we presented at the American Diabetes Association a few years ago. Just under 200 patients with diabetes followed for 2 years. The 2-year mortality, 53%. If you'd had an amputation, just of a toe or part of a foot or a leg, 3 out of 4 patients are dead in 2 years. This is worse than almost every form of cancer. It does not have to happen. We should be screening and preventing diabetic nephropathy and foot problems. But here is another tale, and that is that patients, when they've had a renal transplant, dialysis is miserable, especially if you've got diabetes and autonomic neuropathy, you've got postural hypertension, you feel terrible, you go home and feel rough, and you forget about your feet. But when you've had a kidney transplant, suddenly it's a new lease of life. You're off, but you've still got neuropathy. Here's some papers recently looking at risk of problems, foot problems, after transplantation. Those who've had a simultaneous pancreas kidney transplant, we're seeing a lot of foot problems. These patients are high risk because they're so much better. They're off insulin, they're off dialysis, off they go, and then they turn up with a Charcot foot. They forget they've still got problems because they've lost the gift of pain, which I'll talk about in the next lecture. One study reported a 10% incidence of foot ulcers in the first year after pancreas transplantation. So remember, patients with diabetic nephropathy have comorbidities, especially the other, almost always have retinopathy and neuropathy, high risk of foot problems. The highest risk of all for foot ulceration is a diabetic patient, neuropathy on dialysis. Remember that. So we have an integrated renal transplantation therapy, hemodialysis, PD, and the transplantation program. We do about 50 SPKs a year, and our chief surgeon is from St. John's in Bangalore, Titus Augustine, now professor of transplant. So take-home messages. Diabetes, of course, is increasing. Diabetic nephropathy is common. Screen for it, and you can do something about it early. You don't need to get to the end stage. The consequences of untreated nephropathy are grim. We should screen on a regular basis. Early and aggressive multifactorial treatment and microalbuminuria isn't just a test result you file, it's a call for action. And I'm exactly on schedule. Dhanyavad. Farewell thought for you.